Most of the time, have hyponatremia, but it can vary. And this is very important here. So you will have hyperkalemia in most patients, but you have to know that most of your patients are potassium deficient. So why they are hyperkalemic? Because extracellular shift due to the acidosis, and because of the low volume state that will reactivate the renal angiotensin system. However, if your patient was starting with hypokalemia, that indicates profound dehydration. Okay. Have you heard about euglycemic DKA? This is less common, but we start to see it more now lately due to the and typically this is associated with sodium glucose cotransporter 2 inhibitors. It's very challenging because patients will present with normal blood sugar, so there is a chance that you miss the diagnosis of DKA. Okay, I like this quote by Albert Einstein. You don't understand something unless you can explain it to your grandmother. Same for the DKA. So if you want to understand the DKA, we have to go through this. We have to go through this, but that will be torturing. So I found this simplified version of the pathophysiology. And the pathophysiology starts with low insulin or insufficient insulin. That will result in hyperglycemia. Hyperglycemia will cause glucosuria, osmotic diuresis, dehydration, and hyperosmolarity. Also, dehydration will activate renal angiotensin system, and that will result in potassium deficiency. And because you don't have a source of energy, you will go for alternative path, which is lipolysis, and that will create ketone body, and that will result in metabolic acidosis. Like, what are the precipitating factors for DKA? Common ones in the blue, less common in the green. So common non-compliance, new onset diabetes, we talked about this several times, infections, and inadequate treatment. And yes, shamefully, this can happen in the hospital. Less common, CVA, MI, pancreatitis, drugs. Okay, management. So let's go back to our case. How would you manage this patient? Okay, follow the protocol, raise your right hand. Don't follow the protocol, raise your left hand. Okay, so follow the protocol. Why do we need to follow the protocol? Because we don't want to be in this position. Okay, and protocol, they really help and they really work. It decreases the ICU length of stay, it decreases the hospital length of stay, and it's actually decrease the time to close the anion gap and the ketone body clearance. So this is a national data from University Hospital in Riyadh. It showed that after implementing the protocol, the length of stay went down from 107 hours to 68 hours. That is a lot of time, my friends. So if you put this change in a bigger scale, that implementation result in saving the hospital 1,700 bed days per year per 1,000 patients. So that is a win-win situation. So in DKA protocol, there is no you, there is no I. It's a teamwork, okay? And everyone is responsible to make the DKA protocol executed. So where do we find the protocol? I guess every institution, they have their own protocol. If they don't, you can use the MOH or one of the society protocols. Regardless of what protocol you are using, most of the protocol, they are actually addressing these important points: fluid and electrolytes, insulin administration, bicarbonate administration, monitoring the response, and transition to sub-Q insulin. The goal of any protocol is to restore the volume and tissue perfusion, correct hyperglycemia, acidosis, and electrolytes, and monitor any complications and identify the causative event or the precipitate. First step in management is IV fluid. This is the most important step in management. And that is not any fluid, that is a lot of fluid. So if your patient in shock, you need to give them fluid boluses until they're hemodynamically stable. If the patient are hypovolemic but not in shock, and this is the case with most of our patients, so you need to give them isotonic fluid infusion, but this is actually a very high rate infusion. It's 15 ml to 20 ml per kg per hour. So if you have a average 70 kilo patient, that will be approximately 1 liter to 1.5 liter per hour. That is not 60 cc per hour, that is not 50 cc per hour. So after a couple of hours with this aggressive hydration, you need to adjust your fluid composition based on your patient needs. So look at the hydration status, look at the sodium level, glucose, and serum osmosis. And this just to give you a hint how much and how severely a DKA patient can be deficient in free water and major electrolytes. So on average, a DKA patient will be a 6 liter of fluid, a free water deficit. And I want to bring your attention here to the potassium. Although most of patients will be hyperkalemic, but there will be 3 to 5 MEQ per kg potassium deficit. So if you go back to your 70 kilo patient, that will be 200 to 300 milliequivalent of potassium deficiency. So don't be shy when you're replacing potassium in these patients. Now the $1,000 question is, what type of fluid should be used? It's isotonic fluid, but what exactly or which isotonic fluid you should be using? We have normal saline, we have Ringer lactate, we have plasma light. So which one would you choose? And many people actually stand against using normal saline for DKA hydration. And the whole thing is because the normal saline is not a physiologically normal fluid. Look at this here. This is the plasma concentration of major body electrolytes. And if you compare that to the normal saline, you can see a huge amount of chloride in the normal saline in comparison to the plasma. And you can see also that the pH of the normal saline is actually acidotic. So if we are treating a patient with acidosis, why would you give them something that will make them more acidotic? So this is one side of the debate. If you compare that to the other more balanced physiologic fluid like Ringer lactate or plasma light, you can see here you have close to normal chloride in the Ringer lactate and almost normal chloride on the plasma light with a pH that is better than or more alcoholic than the normal saline. So this seems to be theoretically more appropriate fluid to use with DKA hydration. Now, if you want to see what's the effect of the fluid on the pH, look at the red line here. This represents the normal saline infusion, and this is the patient pH or the blood pH. As soon as you start infusing normal saline at 30 ml per kg per hour, you will see that the pH start to trend down. Okay, but that is not the case with the Ringer lactate. I'm sorry, my laptop is acting up. So, okay, there are few studies that have tried to compare sodium chloride with balanced fluid. So the first one, Scoop DKA, it compared sodium chloride compared to plasma light, which is a physiologic or balanced crystalloid. And they found that patients have a faster resolution of DKA with the plasma light group. And again, another study, they came with the same conclusion. This is another study compared ringer lactate to normal saline. And you can see here the dashed line over here. This is representing the ringer lactate. And you can see that the ringer lactate group, they have a faster time reaching to a pH of 7.32. So you have a nice separation between the two lines. And these are two famous recent clinical trials that are comparing balanced crystalloid to saline in non-critically ill patients as well as critically ill patients. And they looked at the composite outcome of death, need of renal replacement therapy, and renal dysfunction. And they found that the balanced crystalloid have a lower incidence of this composite outcome. But that is not specific for DKA patients. Year later, they did subgroup analysis, just only looking for the DKA patients from these two studies. And they actually found that the balanced crystalloid, the blue line, have a faster time of DKA resolution. You see the nice separation in the two lines, and they have a faster time to be disconnected from the insulin infusion. So clearly in these studies, I showed you that balanced crystalloid is superior to normal saline. But okay, I was looking to hear from you about your practice, but due to the time, I'm just gonna move on. So what is the second part of management? IV insulin, okay? And so you need to know that insulin here is not only to lower blood sugar, it's also to lower the blood ketones, okay? So most of the protocols, they are following a weight-based fixed dose insulin, which is about 0.1 unit per kg. And they keep that rate going until the blood sugar goes around 250. At that time, they cut down the dose. And if the blood sugar go below 250, they add dextrose to the fluid. So a question here. You started DKA protocol, okay? And your patient is now on D5 FNS and insulin infusion. Blood sugar is 75. What should you do? A, hold insulin. B, keep insulin. Keep insulin, yes, because you always can add dextrose to your fluid, okay? And this is another time I want to emphasize that insulin is not only for blood sugar. Although you reach normal blood sugar, but you still need the insulin to correct for the acidosis. But that is another question now. Patient now is on D10, okay? And you lower down the insulin infusion to the lowest dose, and his blood sugar now is 170, but his potassium is 2.9. What should you do? Hold insulin infusion and replace potassium, or switch to D5 half an S, keep insulin, aka kill the patient. This is no brainer, okay? So hold insulin and replace potassium, because literally, if you kept the insulin infusion in a patient with potassium of 2.9, they can die, okay? So remember, these patients, they are potassium deficient, and adding the insulin will make them even more deficient. So if you keep the insulin, their potassium will tank down. So as a rule, you hold the insulin if the potassium is less than 3.3, and you need to aggressively replacing their potassium. Okay, have you heard about the 2 bags method? Did anyone heard about this? Huh? Okay, so the conventional method that is in most of the protocols is actually using one bag of a fluid at the time. And we titrate the insulin according to the blood sugar. And we add dextrose if we have to. However, the 2 bags method, we connect the patient to 2 different types of fluid at the same time. The first bag is half NS with electrolytes. The second bag is D10 NS. And you have 3 possibilities here. You have, if you have your blood sugar more than 250, you're just gonna run the half NS at 250. If you have the blood sugar of 150, you're gonna actually run the fluid at 250, mainly D10. But if you have anything in between, you're gonna give a little bit of this and a little bit of that. The whole idea about this method is to keep the insulin running at high dose. So that is the whole concept. You don't titrate insulin at all. Insulin will be 0.1 unit per kg per hour. Like, did that method work in reality? So there was one study was published by University of Michigan. It compared the two groups. Okay, 68 patients managed in the 2 bags method, and 107 patients were managed in the 1 bag method. And what they found was the 2 bags method, they have faster time to reach normal bicarbonate. They have a shorter time on insulin infusion, and they have fewer fluid bags being charged to them. And although they have been on higher dose of insulin, they didn't have hypoglycemia, they didn't have hypokalemia. So that is a promising study, but not enough to change our practice. If you are interested, watch out for this study, clinical blind randomized clinical trial that will come out at the end of the year. It's actually assessing the 2 bags method in adult with DKA. Okay, so how we typically give sub-Q insulin when patients are out of the DKA. But how about if we start the sub-Q insulin at the time of the DKA? Like if the sooner the patient come to the unit and they start the insulin infusion, we start the sub-Q insulin at the same time. So there is several studies that try to assess this method, and they actually found that this method was well tolerated, and it's showed faster resolution of acidosis, lowest dose of intravenous insulin being used, and potentially lead to shorter length of ICU stay. I personally like to use it just because occasionally your patient will be disconnected from insulin. Patients will go AMA, patients will go for procedures or surgeries. So you want them to be covered with insulin all the time. And this will prevent rebound hyperglycemia when you stop the insulin. Right? So the third part of management is bicarbonate. And the real question here is, does bicarbonate really help? And do we really need to give bicarbonate to our patients? So there is one early study that tried to look for the effect of bicarbonate on DKA patients, and they enrolled 21 patients with pH between 6.9 to 7.14. 10 patients received bicarbonate, and 11 patients they didn't. Okay, and they looked for the decline in the glucose, the decline in ketone level, and increasing the pH of bicarbonate. And guess what? They found no difference. Okay, another study that has more specific criteria pH less than 7.0, for larger number of patients, 44 in the treatment group and 42 in the control group. They looked for the time of resolution of acidosis, hour in continuous insulin infusion or hospital discharge. And again, guess what? No difference. Right? So do we need to give bicarb? Is there any harm with giving bicarb? Yes, bicarb is not innocent medication. If you give bicarb, your blood bicarbonate will go up. That is a good thing. But remember, when the blood carbonate will go up, there will be decrease in hyperventilation drive. That will result in increase in the PCO2. So what's the deal with this? So if you have increase in the CO2, remember the CO2 will cross the blood-brain barrier faster than the change in arterial bicarbonate. So even though that your pH will improve, but patient's cerebral pH will fall down. And bicarbonate will cause hypokalemia. This is another potential risk. And these patients, they don't need any reason to be hypokalemic. So the right answer, I don't know if we should use bicarbonate or not, but many experts, they think that fluid and insulin alone will fix the acidosis, and bicarbonate should be only reserved for patients who are about to die, basically. Okay, treatment pitfalls. What can go wrong with treating patients with DKA? Obviously, hypokalemia, cardiac arrhythmias, we talked about this, hypoglycemia, cerebral edema, and non-cardiogenic pulmonary edema. But I want to focus more on intubation. You have this patient, distressed, tachypneic, and you are asking yourself, should I intubate or not? Why early intubation could be a problem in these patients? Intubation is very high-stake procedure, and it carries significant risk, especially in these patients. Remember, these patients have severe metabolic acidosis, and they are tachypneic for a reason. They are trying to wash out the CO2 as their compensatory mechanism. So if you decided to intubate them, you're going to use sedation, neuromuscular blockade, and that will involve apnea time. You're going to start ambu-bagging, and I'll assure you that your ambu-bagging is not as effective as the active respiration. And there is a risk that you will put inappropriate setting for your patients. So on top of that, you're adding the ET tube resistance, and patients on mechanical ventilator, they have passive expiration, which means that the air will leave passively, as opposed to active inspiration and expiration in patients with tachypnea. So all this together will block the compensatory mechanism, and the pH will go further down. Patient may arrest during the intubation process. So how do we monitor our patients? Blood sugar hourly, VBG, electrolyte, ketones, and OSM every 4 hours. When can we call patient is out of the DKA? If they have a normal pH, normal anion gap, blood glucose less than 200, bicarbonate of 15 or more, and patient is able to eat and drink. And then we transition them to sub-Q insulin if you are not already give it during the initial days. Okay, who are at high risk? Obviously, end-stage renal disease and heart failure. They don't like fluid. Okay, so giving them fluid will actually harm them. Pregnancy, they're at high risk because pregnancy will make everything complicated. And COVID-19. So why COVID is challenging? Because patients with COVID and DKA together, they actually requiring frequent care. And especially during the pandemic, we have ICU bed limitation. So that will add another challenge. Healthcare worker will need to go to the patient room every hour when they're treating them for DKA. So that is a challenge for them. Personal protective equipment shortage, that is another challenge. And the most important one, which is a patient related, is we are using steroid in COVID patients, so that will make DKA management more difficult. And many patients, they have severe ARDS. So these patients, they actually need to be on the negative fluid balance side rather than having a positive fluid. That in my lecture. So what did you take from this meeting? Like what is the take-home message? Do not underestimate the DKA. It's a serious and life-threatening condition. DKA complications are real ones. Try to avoid them. Know the protocol. I've seen many young physicians, they're actually doing things that are not consistent with protocol, like they're holding insulin infusion inappropriately. They are giving bicarbonate for pH of 7.2. So you should know what's in the protocol. And ordering the protocol is something, and executing the protocol is something else. So you need to be at the bedside, making sure everything is done in timely manner, and try to prevent DKA from happening. It's much easier and safer. And thank you very much. تفضل. Okay, so it's actually very challenging to manage these patients. Definitely, you need to be less aggressive with fluid, and definitely you need to get the nephrology or renal team on board early on. So in case of you need to do dialysis, either because of severe metabolic disturbances, they can help you with that. And even if patients get volume overloaded, they may need to offer him additional session of dialysis. So definitely this patient needs to be managed in critical care setting where the management is actively involved, every team in the DKA, endocrinologist, ICU physician, and the renal physicians. So you mean adding additional bicarb, intravenous bicarb, or using the bicarb during dialysis? Yeah. So end-stage renal disease are different because they're actually getting bicarb during dialysis. So if they receive like according to what bicarb path they're using, but most of the time they will get some bicarbonate during dialysis. So they're needing bicarbonate, as opposed to non-end-stage renal disease. This is the patients where we talk about bicarb can be potentially harmful. Type of fluid, same, yes, same. So so you give, but definitely you will give at lower doses. So you start the hydration with isotonic fluid, depending on what you choose, isotonic saline or Ringer lactate. And I think they will be managed the same, except how much fluid you'll be giving. Yeah, I don't know what's the answer for this, but I think you should be moderate with the fluid. You don't treat these patients just like You don't treat end-stage renal disease just like you are treating a 16-year-old boy. So you need to lower down in the fluid, because remember, if you put them through volume overload, they may end up with pulmonary edema, requiring intubation, requiring life support. Many complications. You don't want to go there. Okay.
Sometimes some people and we have some things this decision that between the children the way so time and start learning so sometimes as usual
Right. Yeah, that's totally agree. Totally agree.
any question?
I personally, I personally using ringer lactate, because I obviously see when we are using normal saline, the fluid that is rich in chloride, I see that the chloride in the second or third days it starts to go up, and now we are getting to develop non-GAB metabolic acidosis. So I see it very common. So that's why I stopped using normal saline for our patients. But again, I understand that the ringer lactate can be limited. Sometimes it's not available in all places. So, but every time you have a chance to use ringer lactate over normal saline, I would suggest that you choose the ringer lactate.
Any question?